Okay, good morning everyone. Thank you all for joining us today for the Greater Manchester Cancer Alliance Breast Education event. We're really delighted to see you all here and just so pleased that we could have a face-to-face event today. And there's a few housekeeping things to go through. So I just wanted to say that you can use the QR code on your tables to get access to the agenda, the speaker bios, and any other information about the event. And I just wanted to thank our sponsors for today. So AstraZeneca, Roche, Novartis, Exact Sciences, Pfizer, Lilly. They've got stands in the sponsors room, which is just at the end of the main room. So please do go and visit them. And we've also got stands and information about the Greater Manchester Cancer Academy and from the charity Met Up UK. So please do go and talk to them as well. You can engage with social media throughout the day using the hashtag GMCABreast23. And thank you to GM Cancer Academy for supporting the organisation of the event today, and for all of our speakers and chairs for supporting the day and preparing such fabulous presentations for us. The sessions will be recorded today, so you'll be able to watch them back on demand afterwards. And there will be an opportunity to ask questions at the end of the two morning sessions in the last session of the day. Lunch and refreshments will be served in the foyer, and if you've got any special dietary requirements, just let a member of staff know. But the main buffet caters for vegetarians. In the event of a fire, go this way or that way. We're not expecting any child fire alarms, so if the alarm does go off, we do need to evacuate the building. So I'm sorry, I didn't introduce myself at the start. For those of you who don't know me, my name's Claire Garnsey. I'm a breast surgeon at Bolton, but I'm also the clinical lead for breast and the Associate Medical Director at the Greater Manchester Cancer Alliance. And on behalf of the Cancer Alliance, I just want to say you are so welcome. And please use the event for networking. We know that times are really tough in the hospitals at the moment, and we just hope that you really enjoy today and use it as a little bit of a team away day and network with some of your colleagues from other units around the region. And please just have a lovely day, have fun, enjoy yourselves, and we hope you really enjoy it. I'm going to hand over to our first chair of the day, Nicola Barnes, who you'll know as one of our surgeons at MFT.
Thanks, Claire. Yeah, my name's Nicola Barnes. I'm one of the surgeons just across the road at Wythenshawe, chairing this first session, which is all things endocrine therapy. What we'll do is we'll run through all the talks and videos we've got, and then there's about 15 minutes for Q&A at the end. So rather than any Q&A between each talk, we'll do that at the end of the session. And if we run out of time for that, because we want to try and stick to time, just approach the speakers during the break and they can answer any additional questions. So back up and down again, back on to Claire, who is doing the first talk about the GM Cancer Endocrine Therapy Toolkit Improvement Programme that's all about to roll out, and the Risk Reducing Endocrine Therapy Toolkit. So back up you come, Claire.
Okay. So yes, so the first session today, as Nicola said, is all about endocrine therapy. And we wanted to introduce those of you who don't know about it already to our ETIP programme. And that stands for Endocrine Therapy Improvement Programme. And it does what it says on the tin. It's all about improving the lives of patients who are taking endocrine therapy. The background to this is that most of us in the room know that 80% of breast cancers are sensitive to the hormone estrogen. And we know that anti-estrogen medications, so tamoxifen, anastrozole, letrozole, reduce the risk of breast cancer recurrence by up to 50% and increases survival. But many published studies have shown that between 20 and 50% of women do not complete their endocrine treatment. And so it's really important, considering how effective these drugs are, that we are doing everything we can to support patients to complete their course. And I think the situation has got more complex in recent years because there is so much currently, isn't there, in the media about HRT and how fabulous HRT is and how everyone should be on it and how there's not risk related to taking HRT. But clinical experts in the region still have significant concerns about taking HRT after a personal diagnosis of breast cancer, or if you're at high risk of future breast cancer, estimating that perhaps HRT increases your risk of recurrence by 2.5 times. So it's really, really important that we're giving women sensible, evidence-based information about hormone therapy and HRT. The other reason why at the Alliance we wanted to focus on ETIP is because it affects the whole patient pathway. So we've got patients on endocrine therapy for risk reduction, so to try and prevent breast cancer. Of course, we've got patients with primary breast cancer taking it for adjuvant and neoadjuvant purposes. We've also got patients with metastatic breast cancer taking endocrine therapy. And then we have that smaller, frail group of patients who are unable to have surgery, who are on endocrine therapy. So by implementing this, we can impact so many different people throughout the pathway, and it's not just focusing on one group. So what are the aims? Well, we were sort of thinking, right, what do we need to acknowledge? Well, we need to acknowledge that there is a big population of people on endocrine therapy, and that it's highly effective and really cost effective. So sometimes we're looking at systemic anti-cancer treatments that cost a fortune for a small benefit. This is a well-known drug that is cheap and highly effective. So we need to use this to its maximum benefit. We know that endocrine therapy has side effects, but that the side effects vary between patients. But for some patients, the side effects significantly reduce quality of life, and because of that, people discontinue medication. So the purpose of ETIP is to provide support for patients taking endocrine therapy at any point of the cancer pathway. And we really just wanted one place that you go to. So sort of one online destination where you're going to be able to get lots of endocrine therapy information and resource, whether you're a healthcare worker or whether you're a patient. And it really ties in with the national ask of us. So you'll hear later in the day this afternoon from our Managing Director at the Cancer Alliance, Claire O'Rourke, a bit about what the Alliance does and what the national team, NHS England, asks us to do. But we're certainly being asked to deliver the cancer goals of the long-term plan. And one of the big cancer goals is that by 2028, we want an extra 55,000 people each year surviving for 5 years or more after the cancer diagnosis. And if we can support more patients to complete endocrine therapy, we can reduce cancer recurrence, and increase survival. So this is what we're planning, and it doesn't mean that this won't expand, but this is where we're up to so far. So the first part of ETIP, which I'm going to talk to you about in more detail shortly, is all about risk reduction. So improving equity of access to risk-reducing medication. And we know that at some units in Greater Manchester, East and Mid Cheshire, we are not offering risk-reducing endocrine medication at all. And we want to try to increase that. We've set ourselves a target in the first instance of 20%, because we know that will reduce cancer incidence by up to 50% in this group. And some of these women have a 1 in 3 lifetime risk of breast cancer. The next part of ETIP was about dealing with that HRT issue. So we wanted to provide something quickly, so we had evidence-based information about HRT for women who have had a personal history of breast cancer. And this has been accessible online for a little while, and I'm delighted to say that we have this available in 20 different languages. So you just log onto the website and you can get hold of that HRT information leaflet and use that for your patients. It's also really good to send out to primary care colleagues if they've got a question about HRT in someone who's had a previous breast cancer. The next part of ETIP is what Kate Williams will be talking to us about shortly, so I'm just going to touch on that, and it's all about the work that Kate, Nicola, Anne Armstrong and their team are doing to provide us with a really high quality, accessible education resource for us as healthcare workers to access about endocrine therapy, and Kate will be talking to you about that after I've spoken today. And then going forward, over the next 12 months, We really want to focus on the resources we're providing for service users. So we've been lucky enough to get a grant from the personalised care team at Greater Manchester Cancer to make some patient-facing information videos. And we're hoping that Claire Lou, I don't know where she is, but she's here, our lead nurse for cancer at Greater Manchester Cancer, will be leading with many of you who attend the CNS and AHP forum on those videos. So I'm hoping that lots of the CNSs in this room will be filming later this year and we'll get you online. We're also planning to make some videos of patients, and you will see one video that Amelia has kindly done for us a little bit later today. And what we're hoping is to really amplify the patient voice and share that experience, but to show the range. So you might be someone who's on risk-reducing endocrine therapy, or you might have metastatic breast cancer and be on endocrine therapy. You might be getting very few side effects, or you might be getting loads. And we want to show that variation so there's not a single voice about endocrine therapy. So those resources, some are already online. So the team has been working really hard behind the scenes to get this ready for you now. So you can go online to the GM Cancer Alliance page and you click through to the endocrine therapy page and you can access a number of these resources already. There are more to come. Claire Goldrick and I are expecting the patient information leaflets to be going online in the next week or two, and then there'll be more patient-facing resources coming online over the next 6 to 12 months. So please keep checking in to see what's coming out on that page. So that gives you a bit of a whistle-stop tour about the programme, about ETIP. And then I'm going to focus a bit on the risk-reducing endocrine therapy part of that programme. So the toolkit is already online. So if you go to that endocrine therapy page, you can click through to the risk-reducing endocrine therapy toolkit already. You can also use the QR code. And we want you to use those. So we want them to be used and adapted. So adapt and adopt and use it in your units for your family history clinics as you see fit, as works well for you. The reason why we're doing this is it's very clear in NICE guidelines that we should be doing it. So NICE have told us for many years that we should be offering risk-reducing endocrine therapy, but it's been very hard to implement, mainly because our family history clinicians and specialist nurses are so stretched. NICE says that we should be offering chemo prevention. That's a slightly old-fashioned term now. We tend to use the words risk-reducing medication now, but we should be offering it to high-risk individuals. So those are people with greater than an 8% 10-year risk of breast cancer or a lifetime risk greater than 30%. And we should be considering risk-reducing endocrine therapy for those at moderate risk. So that's a risk of 3 to 8% over 10 years and a risk of 17 to 30% over lifetime. I think the NICE guidelines are a bit woolly when you look at that. What does offer mean? What does consider mean? But actually, if you read the small print, it becomes a bit clearer. So with the high-risk patients, offer means it's a strong recommendation. So they use offer when they are confident that for the vast majority of patients, the medication will do more good than harm and be cost effective. So they're saying recommend it for the high risk. For the moderate risk, the word discuss is where you should consider it. So they're still confident that the medication will do more good than harm for most people and will be cost effective, but there may be similarly cost effective options. So it's more of a discussion, and it's likely that the patient's view will carry more weight. What do they want? What's important to them? So that's a discussion. So why is this in NICE guidelines? Well, the evidence is clear from the research that we've got and that has been published that using risk-reducing endocrine medication reduces risk by 50% for anastrozole, 35% for tamoxifen, and between 25 and 30% for raloxifene. However, we know that only about 10% of patients who are offered risk-reducing medication take up that offer. And a recent study has shown that less than 2% of women who are on a breast screening program because they're high risk have even heard of risk-reducing medication. So throughout the country, so we're not putting a spotlight on Greater Manchester, we're trying to get ahead of the national picture. Throughout the country, we're not even telling women there is this offer to reduce their risk of future breast cancer by 50%. It's either mammograms or risk-reducing surgery with nothing in between. So we need to rectify that. We did do some further investigations of what was going on in the region ourselves, and that was a little while ago now. That was at the end of 2021, because we knew that this national picture was looking a bit dire. And so we thought, well, what's going on in Greater Manchester? We know we've got great family history clinicians out there. Are we offering risk-reducing endocrine therapy? Or if we're not, why are we not doing that? So we sent round a survey, and all of the 7 units in Greater Manchester, East and Mid Cheshire answered that survey. We excluded the very few consultants, consultant doctors, not consultant nurses, who were offering these clinics, and just looked at the non-consultant workforce. And what we found is, although this was a specialist family history clinic, only one of the clinics felt confident to have a conversation from start to finish with a patient about risk-reducing endocrine therapy. We found that 60% did discuss it to some degree, 40% didn't discuss it, but of those people who did discuss it, only 2 of the units could prescribe it. So the 5 other units were either referring to another family history clinic or referring back to the GP. And I think, considering that we're specialists and we're finding it hard to discuss this, it's a lot to put onto our primary care colleagues. So we set up a steering group, and there's lots of people in this room who were in the steering group. We had, of course, family history nurses. We had Sasha Howell, who's been very supportive, one of our medical oncologists who has a specialist interest in family history. We had geneticists, we had genetic counsellors, of course we had service users, we had members of the team from GM Cancer. And within that, we also had GPs, primary care colleagues. And we all agreed that it just wasn't appropriate to expect general practitioners to have this very specialised discussion with patients. But all of our GP colleagues who were involved were very open to receiving advice from us about this specialty issue. And they were very used to working in multidisciplinary teams. GPs work with specialist nurses all the time, and they didn't have a problem with receiving advice from our highly qualified specialist nursing team, but they wanted that to be clear. You know, always top of the letter, make it very clear and accessible for all the busy GP colleagues. We know that GPs manage menopausal symptoms really regularly, but a lot of our primary care colleagues didn't feel confident in managing those menopausal symptoms for patients who have had a personal history of breast cancer or are at high risk of breast cancer, and they were really keen for additional advice about that. So we're in contact with our GP colleagues, and as I tell you about the rollout of the risk-reducing endocrine programme, please bear in mind that we will continue to communicate with primary care and offer them education sessions as we roll this out, so it's not coming as a surprise to them. So this is the toolkit. This is what the steering group decided to do. We decided we needed a toolkit to make it a bit easier for our family history clinicians to implement this and offer this medication to patients. We've designed an assessment document, treatment algorithms to decide whether someone is eligible for endocrine therapy and which tablet to start them on, patient information leaflets, a prescription document, and we've also looked at the workforce need. So what we wanted to provide is this really safe, standardised, approved pathway of care that our specialist nurses could feel really confident about, and our GPs could feel really confident that those specialist nurses had done a very thorough, complete assessment. So the assessment document, we actually based this, the starting point was based on the treatment summary that we all use in end of treatment clinics, because that's a regional document that we all use, and we remove boxes and we make this document that's suitable for the patient, that's suitable for the GP, that's suitable for the notes. And that was the principle we went on to try and make it time-saving and efficient. It means that the risk-reducing endocrine therapy assessment is fully integrated into the assessment that the specialist nurse is doing in clinic. It's not an add-on at the end. Now, it's not mandatory to use this assessment document. If you are a highly experienced member of the family history team and you feel you don't need this, that is okay. But if you haven't got the confidence in prescribing these drugs, you know if you go through this assessment document that you have checked everything and you are highly, highly unlikely to make any mistake in terms of what you advise GPs to prescribe. This is the assessment document. Looks like a lot. But once you get used to using the assessment document, you go through that very quickly because you get used to, I delete that bit if they're moderate risk, I leave that bit in if they're high risk. And we will go through these. We've already talked through with the family history nurses these documents already in a workshop earlier in the year, but there will be further sessions for our family history teams over the next 12 months. The algorithms are about decision making. So are you eligible for risk reducing endocrine therapy? Which tablet to start on? And we've got one for premenopausal women, one for postmenopausal women. And our perimenopausal women go in with the premenopausal women group. It considers contraindications and the type of medication, and we hope it really increases our family history clinicians' confidence in making that decision. It's really important that these algorithms have been approved by the Greater Manchester Medicines Management Group. So they've approved that this is a really safe way to determine which medicine patients should be on, and that means that they feel confident that our nurses can be advising our GPs about this. These are what the algorithms look like. I'm hoping that our family history clinicians will start to save these on their desktops or print them out and put them up in clinic. And then we heard from our family history clinicians that they weren't completely happy with the patient information leaflets that were available. We were using lots of different information leaflets around the region. Some of them didn't look great. Some of them were pages and pages long. Some we were worried that people with a lower reading age would struggle with. So we decided to design our own. And those of you who've been involved in the steering group know that we got up to version 9. So there's been a lot of care and attention made to try and make this as easy read as possible, but also really informative. And I'm delighted to say that we were also able to get some money from Greater Manchester Cancer to get these formatted professionally. So they look gorgeous. There's a different one for tamoxifen, anastrozole and raloxifene. They look really professional. We've obviously made sure we've considered diversity in our imaging. We've considered our language very carefully. We've used infographics to make it as accessible as possible, because we all know discussing risk is not easy. So those are a whisker away from going online. So just bear with us for another week or so and you will be able to access these. So that takes us to the prescription document. So you're a family history clinician in clinic. You've done your assessment, perhaps using the assessment document. Your patient is eligible for endocrine therapy. You've gone through the algorithm and worked out which treatment is the treatment you should be safely offering her. You've given her the patient information leaflet. She's maybe gone home to think about that for a few weeks, and then you're following it up with a phone call. You've not got her there, and also you might not be a prescribing nurse. What do you do? Well, you can fill in this prescription document. And this too has been approved by the Greater Manchester Medicines Management Group, that specialist nurses can issue this document if they're using the toolkit to advise our primary care colleagues to prescribe the medication. So you do not have to be a nurse prescriber. And that's because tamoxifen and anastrozole are on the green list. And what that means is GPs can initiate these drugs following specialist advice. We don't have to write the first prescription. Raloxifene currently is a little bit different in that we do have to initiate from secondary care. But I think most of the patients will be offered tamoxifen or anastrozole. But with raloxifene, you would need to be a nurse prescriber or get one of your doctor colleagues to be able to fill in that first prescription. Still send out the prescription document, but then the GP will continue it after that. So this is what the prescription document looks like. We couldn't quite get it onto two sides, but the blue box at the top, you actually delete. And there's a few deletions, so it does sort of shift. It's not a very long document. And of course, we've put the actions for GP in a big bold box to make it easier. So that takes us on to workforce. We know that the whole team, everyone here, is really, really stretched at the moment, and that is no different for our family history clinicians. So one, we tried to make the toolkit really streamlined, but also we were trying to look at workforce solutions. And what we were able to do is we were able to try a GPER pilot. So that's GP with an extended role in breast disease. We've got a number of our GPERs with us today. And I must say it's been a wonderful pilot to be a part of. It's been lovely to meet colleagues in primary care, and they are doing a fantastic job integrating with the wider breast workforce. So thank you to the GPERs. But the role of the GPERs, it's just a pilot for now. So it was funded by Health Education England for 12 months, and we have 6 GPs, one in each of our units in Greater Manchester and East Cheshire. We've provided an online education programme for our GPs, 14-week course, 2 hours a week, and we give time to do that. And that was in collaboration with the National Breast Imaging Academy, who've been incredibly supportive. And we do some face-to-face learning as well through the Alliance. And our GPs work maybe 1 or 2 days a week still in primary care, and then they work with us for 2 days a week, delivering one-stop clinics, nostalgia telephone clinics, family history clinics. And so it's providing that extra workforce to roll out this really important pathway. And we just hope that we will be able to keep all of our GPRs once the pilot is over. So I think just as I'm concluding, I always think it's worth thinking about, well, why haven't we implemented it before? Workforce, not having enough time in clinic. But I also was thinking whether we have any biases ourselves. You know, do we have preconceived ideas about the side effects of endocrine therapy? I think a lot of medics do, because we only see people coming back to us who have loads and loads of side effects. So I think we do get a bit of bias. And I think it's how we value prevention. So we're making time to talk to patients who have a diagnosis of breast cancer. We make time to talk to them about endocrine and prescribe endocrine therapy, but we're not at the moment finding that time and prioritising risk reduction. Risk reduction, it's prevention for some people. You know, we need to prioritise this. This needs to be something that we are delivering. And it's just questioning ourselves about how we feel about that change. So how can you help? So please amplify the message. You know, make sure that in your units you are having a conversation about risk-reducing endocrine therapy if you're not already. If they're not in this room today, have a discussion with your family history team. Do they know about this? They should. Are they engaging with us? And please, please make sure they are freed up to attend the sessions we're having with our family history clinicians, which we're aiming to hold 4 in the next year, just to support them, some on Teams, some face-to-face, to support our family history clinicians to implement this pathway. I think if you're not able to implement it, it needs to be highlighted to managers and clinical leads that this is in NICE guidelines. This is a regional rollout programme. We need to be doing it, thinking about capacity, thinking about keeping that GPR. Because we need to make sure we've got the capacity, and we need to be thinking about, can we streamline the pathway any further? It might be with these new tools that you can streamline your pathway a little bit by stopping doing some of the dictated letters, for example. And we'll have some opportunity to share and learn from each other at the next session we're holding for the family history clinicians, which will be in January 2024. We'll send that date out as soon as we can, and we're hoping to hear from all the different units about how they're getting on with this and make sure that we're supporting everyone to roll out the programme. So that's me. I'm going to hand back to Nicola now.
Thanks, Claire. It's all really very exciting kind of developments in the endocrine therapy world here. And GM Cancer, I think that hopefully we are kind of leading the way with all of that. It's all very important to not just get the clinician voice, and the next little 5-minute video is the first in a series of videos that Claire has alluded to, that are hopefully going to be up there for everyone to see about the patient's perspective of actually being on kind of tablet treatment. So the video that hopefully is going to start in a second when I press a button is a 5-minute video from a lady called Amelia Cargo. Who's taking tamoxifen to reduce her risk of breast cancer, and she shared her experience and her advice for other women considering taking risk-reducing endocrine therapy. So let's hope magically this will work.
The reason why I was referred to the family history clinic is that my mum was diagnosed with breast cancer when she was 35. And she died of breast cancer 10 years later. So she was very young when she was diagnosed, and she was young when she died as well. And also my auntie was diagnosed with breast cancer when she was 60. So that triggered me to go to my GP and be referred to the family history clinic. So I've been at there for about 6 years now. For my first appointment, I met with the nurse, and she was very reassuring. She explained to me that my risk was 1 in 3, which I wasn't expecting. That was actually quite a shock, but she really made me feel supported, and it was a really safe environment. And she explained to me that I had a whole range of options from, you know, I could choose not to have any intervention, or I could start having yearly mammograms, eventually go on to tamoxifen, which is a hormone drug, and even potentially explore risk-reducing surgery. So she really put the power in my hands, I'd say, like really like patient choice was at the front of everything she was saying to me. So I started then having yearly mammograms, and then from the age of 35, which is about 6 months ago, I started taking tamoxifen, as that was the first time that I was sort of recommended to start taking it. And that happened. I had a chat with a consultant who explained to me that because I was fairly young, that I might not experience any side effects, but if I did, they would be things like hot flashes and night sweats. But he also explained that if it wasn't working for me, I could stop. And I just thought, well, why not? Like, just give it a go. And I've been lucky enough not to have any side effects, and I'm fine on it. I had a really good think about sort of the benefits and maybe the side effects of taking it. They gave me a leaflet to take away. There was no pressure to make a decision. I did some research. I spoke to my girlfriend and family members. I had a consultation with the consultant and sort of made a list of questions beforehand. And actually, he really put me at ease, because he said, as you're younger, you may not experience them, and it's completely your choice whether you keep taking it or not. So I had a really good think through it. And at the end, I just thought, I've got this high risk. I want to do something about it, and this is my way of taking control of that. So I decided to take it. I think just what really helped me in making the decision is that they gave me time to think about it. Having the consultation with the doctor, speaking to family and friends. Obviously, my auntie has breast cancer as well, so I spoke to her. But I think it was just mainly that personally I felt it was really important for me. I found that taking tamoxifen has really done a lot for my peace of mind. I know that it's doing something physically for me, but I found that I'm much more at peace within myself as well. And I think that's because psychologically I know that I'm doing something to manage my risk myself, and I can't control what's going to happen in the future, but I know that I'm doing what's best for me in order to make sure I'm doing the best thing that I can. I would say to other people in my position is that I sort of had some hesitations about taking tamoxifen initially, because I think in my head, I was taking a drug that would put me into early menopause. That was my initial, a bit of a misconception, really. But I would tell them to have a chat through with the professionals and, see what they have to say about how it might work for you. And it's, if you feel that it's something that will benefit for you, give it a go, because it's not something that you have to do. You can stop taking it if you want. And I found that I've had no side effects, and I know it's doing something physically to me, but psychologically I found that I'm much more at peace now. I don't think about my risk nearly as much, and that's partly because I've taken these steps to chat through my options, and I've decided that this is the best path for me.
So that's the end of that video. I've not seen that before, but I think it's going to be a really powerful tool for us as clinicians to actually listen and hear to these patient experiences, especially as we roll that out with other ladies in different scenarios. So I think that's going to be great. Obviously, Amelia was saying that she's not getting much in the way of side effects, but that's not the same for everybody. So our next speaker is Kate Williams, and she's one of the consultant breast surgeons and the specialty lead at North Manchester General Hospital, part of MFT. And she's just going to update you on an education programme that we're going to be hosting online. There's going to be some more face-to-face events about it, about how we can support the ladies that are potentially struggling a bit more with their endocrine therapy side effects to continue and stay on the whole of their treatment. So Kate, there we go.
Thank you. Good morning, everyone. So as Nicola has already said, I'm one of the consultants over at North Manchester, but this has been a joint effort. There's 3 of us that have been involved in this project. We've been talking about it for quite some time, and it seems to be gathering a bit of momentum now. So, yeah, just going to talk about what we're going to be doing to try and help with this endocrine project across GM, and that's an endocrine therapy education package, basically, supporting those patients to manage their side effects. So just an overview, I'm going to talk about treatment-induced menopausal symptoms and how many women are affected and why. What is endocrine therapy? So what are we talking about and how does it work? A lot of you around the room will know that, but just for those that don't. And why treatment non-compliance is an important issue. I'm going to talk about what the menopausal symptoms or estrogen deficiency symptoms there are, and talk a little bit about what Claire's already alluded to, which is the kind of HRT and menopause revolution that I'm sure you've all been aware of in the media, but then talk about the evidence behind HRT and breast cancer and what our GM solution is. So, breast cancer is the most common cancer in the UK, with one woman diagnosed every 10 minutes, which is around 55,000 women with a new diagnosis every year, and a further 7,000 women that are diagnosed with DCIS, which is an early form of the disease. There are also an estimated 61,000 women living with secondary breast cancer in the UK, and another estimated 600,000 women who've been diagnosed and treated for breast cancer in the preceding kind of 5 to 10 years. So it's lots and lots of women. It's a widespread issue, and there's now widespread use of systemic breast cancer therapies. So, unfortunately, an early menopause or estrogen deficiency symptoms can be induced, or pre-existing symptoms can be exacerbated by these systemic therapies. And so treatments can be prematurely discontinued by patients due to their significant side effects. So, systemic treatment of breast cancer is dependent on tumour characteristics, and if the tumour is estrogen receptor positive, then patients are advised to have endocrine therapy. An adjuvant use of these therapies are for primary breast cancer, and we recommend that between 5 and 10 years. Alex may be going into that in a bit more detail later on. But it's also used to treat secondary breast cancer as well. So it's lots and lots of women. 70%, 80% of breast cancers are ER positive, and that means that a lot of women are taking these or advised to take these as part of their treatment. Endocrine therapy suppresses the action or production of circulating estrogen and can therefore induce or worsen those estrogen deficiency symptoms. Chemotherapy is another type of treatment, and a substantial number of women are offered chemotherapy as part of their treatment plan as well. It's given neoadjuvantly, it's given adjuvantly or after surgery, and it's also given as part of secondary breast cancer treatment as well. Chemotherapy negatively impacts on ovarian function and can therefore induce an early menopause in women as well. So there's lots and lots of women out there that may be affected by these symptoms. The choice of endocrine therapy depends on the patient's menopausal symptoms. If they're premenopausal, then we tend to use tamoxifen, and that's an inhibitor of the estrogen receptor, and it works by blocking the effects of estrogen on those receptors. In addition, high-risk tumours in premenopausal women, there's gonadotrophin-releasing hormone agonists that stop ovarian production of estrogen as well. And those patients are rendered chemically postmenopausal very quickly, and it can have a big effect on their hormonal status and also their symptoms. For postmenopausal women, we tend to use aromatase inhibitors, not always, but we do tend to use those more. The main source of estrogen for these women are in adipose tissues, peripheral adipose tissues, and the androgens are converted to estrogen by aromatase enzyme. Aromatase inhibitors stop that enzyme from doing that, and therefore there is no receptor, there is no estrogen to interact with that receptor, and that's how they work. 80 to 95% of breast cancer patients therefore experience some estrogen deficiency or menopausal symptoms during their cancer treatment. And up to 40% of women do not adhere to their endocrine therapy as a result. Those most severely affected tend to be those under the age of 50 and those being treated with goserelin or Zoladex as part of their treatment. Non-adherence is most often due to the impactful side effects caused by that estrogen therapy. And there are several studies that demonstrate those patients who adhere to endocrine treatment have an improved disease-free and overall survival. So management of these symptoms is vital to help women not only maintain their quality of life during breast cancer treatment, but also to ensure that they can reap the benefits of that established and effective treatment. So these are the overview of symptoms caused by estrogen deficiency. These are the kind of menopausal symptoms that we're talking about. Vasomotor symptoms is just a different way of saying hot flushes. And the most common side effects experienced by patients who are premenopausal are vasomotor symptoms or hot flushes and sweats, urogenital and sexual dysfunction symptoms. They're reported as most severe in those patients that have Zoladex or goserelin as part of their treatment. Those on aromatase inhibitors tend to struggle more with the musculoskeletal symptoms, so aches and pains within the joints, and that can be really terrible for these women and can really impact on their everyday activities. So I'm sure you're aware and been witness to the recent media reporting around menopause and the importance of women experiencing debilitating symptoms due to perimenopause or menopause being listened to and taken seriously in that request to treatment. And, you know, we all support that for the majority of women. There's no denying that HRT is an excellent treatment for menopausal symptoms in a large number of women. And there's certainly evidence to show that tailored hormone replacement therapy is excellent at managing some of the most frequent symptoms experienced with women with estrogen deficiency. Certainly in vasomotor symptoms or hot flushes, genitourinary and sexual dysfunction symptoms mostly. They're kind of three main symptoms that are really treated very well with HRT. Some of the recent media messaging you may have seen does hint at the fact that HRT should be available to all women and that it's safe for everybody, no matter what their own personal medical or surgical history. I'm afraid to say that there simply just isn't any evidence out there that women with a personal history of breast cancer, that systemic hormonal therapy is safe. In fact, there is some clinical evidence to say it's just not safe and it increases the risk of disease recurrence in this patient cohort. I'm just going to run through the three main trials out there. So the first one is the HABITS trial. It was reported in The Lancet in 2004. That's a Scandinavian clinical trial where women with a personal history of breast cancer that were receiving tamoxifen treatment were offered HRT or not. And that trial, unfortunately, had to finish early. They only had a median follow-up of 2.5 years, and it stopped due to the safety aspect of that. So there was shown to be a hazard ratio of 2.4, which basically means there's at least a 2 to 2.5 chance increase of recurrence or disease event after HRT. So that trial was finished early due to safety concerns. At the same time, there was another Swedish study called the Stockholm trial that was being set up. It was using a slightly different HRT, had a lower dose progesterone within it, and it was a slightly different preparation to the one used in the HABITS trial. But because of the HABITS results and because of the fact it was finished early, this also had to close early. It was thought it was too unsafe to continue that trial. Now, the median follow-up of that trial was at that point 4.1 years. The risk of breast cancer was not associated with HRT within their data, but we don't have the follow-up of that study that was the study was designed for, and as a consequence, we can't take much from that. And then there's the LIBERATE trial, which was actually a randomised trial where patients were put on either Tibolone, which was a type of HRT, or a placebo. So it was a randomised blinded trial. Endocrine therapy, the women were either on tamoxifen or aromatase inhibitors, so we didn't kind of stipulate what type of endocrine therapy they were on. And the endpoint was any cancer event again. And as you can see, the risk of breast cancer again was increased compared to patients taking HRT compared to those taking the placebo. So a hazard ratio of 1.4. The confidence interval didn't go over zero. So basically, there was an increased risk of breast cancer event in those patients taking HRT. So those trials are pretty big, you know, they are well designed, and they did show that increase in breast cancer events in those patients. So this is why we're concerned about women being offered HRT. Results from this study mean that national and international guidelines basically advise women should not, with a personal history of breast cancer, should not be prescribed HRT. But there's this little caveat of unless in exceptional circumstances, and that's always difficult, isn't it? And I think what we're saying is exceptional circumstances should be where a woman is experiencing intolerable estrogen deficiency symptoms, has tried all other alternative therapies to control their symptoms, and has also had the opportunity to discuss HRT and its associated disease of recurrence risk with a secondary care expert before commencing on any form of HRT. It's got to be informed consent. They've got to know the risk they're getting themselves into, and then it's a personal, you know, risk, pros, cons conversation. But it needs to be done in a stepwise manner, trying all the other alternatives first. So, what are the other alternatives? There's lots and lots of alternatives out there. There's lifestyle things that can be advised. There's alternative therapies such as complementary therapies, acupuncture. There's medications out there that can be tried as well. And this will all be revealed in the educational package that we're putting together. But the strength of evidence for these treatment alternatives to HRT is varied. It's out there. It's not. Some of the evidence isn't great. But there is no evidence to say these have a negative impact on breast cancer outcomes, and so they are safe alternatives. And I think we really do need to consider how we advise patients to try these and how we do it in a kind of organised and structured way. So, how are we approaching the issue across Greater Manchester? So, Claire's already talked a little bit about all the things that have been done already. So, I think when concern was first raised about the fact that HRT was being talked about within the media as being safe for all women, the GM Breast Cancer Pathway Board responded very promptly by producing the patient information leaflet that Claire's already highlighted and is available to all. And that's explaining why HRT after a breast cancer diagnosis is not advised. And I think that's been rolled out really quickly, really succinctly, and is a really good response to that initial concern about media reporting. It's available on the GM Cancer website, as we've already said. And it's got lots of different alternatives and lots of different languages out there. So there's a QR code again if anyone missed it when Claire mentioned it before. Moving on from that, what our project is about a Gateway C educational package. It is aimed mostly at colleagues in primary care, but is available to all. I think you can sign up to the Gateway C for that educational package that outlines the risks associated with HRT with a history of breast cancer and gives a practical step-by-step advice about how patient side effects can be managed in a safe way, and outlines how this needs to be a collaborative approach between primary and secondary care. It also outlines the evidence behind some of the alternatives that are out there and the strategies suggested. Alongside that, we're also being filmed in a cancer conversation. I don't know if anyone's seen Rebecca Leon, who's one of the Greater Manchester GPs that is very heavily involved with GM Cancer and the Gateway C. There's these bite-sized videos that are there, like a conversation about what the symptoms are, what the educational package is about. And it's just a bite-sized learning video as well that's going to be out there. I'm not sure we're looking forward to that quite as much as others, but I think it's going to be a really nice way of getting that message out there as an alternative to the media messaging at the moment. And there's also cognitive behavioural therapy. There have been some of our CNS workforce within MFT that have had training for cognitive behavioural therapy. And I think that is one of the alternatives where there's evidence-based that treatment using cognitive behavioural therapy for vasomotor symptoms such as hot flushes, it's there's evidence for it, it works really well. And that's aimed at equipping patients with tools to be able to manage their own symptoms really well. And again, it's empowering the patient, giving them something they can do themselves. And I think some of the CNS workforce have found it very helpful for themselves too. The aim is to set up menopausal symptoms CBT clinics for patients, and if that proves successful within MFT, hopefully we'll be able to roll that across the GM footprint over time. So just a plug, we're doing a endocrine side effects masterclass. I'm not sure why we called it that, but it's on a very special date on the 29th of February 2024. Please save the date. There's lots and lots of people involved, lots of different speakers, including some external speakers as well. And so if you'd like to come along and learn a bit more, we're hopefully going to be in a position to launch the Gateway C educational package at that meeting, let you know where to access it. We also have some future plans. So we're hoping, and we've put a bid in for some funding to develop a specialist endocrine side effects, MDT, to help manage these patients using the tools that we've suggested. There's a similar successful model already up and running in Bath, and that's worked really well. So watch this space. Thank you.
Thanks, Kate, and good plug for our meeting on the 29th of February. Save the date, save the date. So running on from that rather nicely in terms of side effects, the next two speakers are talking about current trials that they're involved in, looking at trying to manage some of these side effects. So the next speaker is Professor Robert Stein. He's a consultant oncologist at University College London Hospitals and Professor of Breast Oncology at the UCL Cancer Institute. So I'd just be grateful if I could give him a warm welcome for his next talk.
Thank you. I have to say I'm hugely impressed by your organisation. I don't think anybody's begun to get anywhere near this in London. So I'm here to inform you about and to promote the BLUSH trial. And this is an NHR-funded randomised trial of non-hormonal treatment for menopausal hot flushes. So a significant number of women seeking treatment for hot flushes are either advised against HRT or don't want to take a hormonal treatment. So there's no standard non-hormonal treatment for vasomotor symptoms, hot flushes. Recommendations by NICE and in other guidelines include a variety of antidepressants, gabapentin and clonidine. And all of these have been shown to be better than placebo in randomized trials. I think the two most commonly prescribed are clonidine and venlafaxine. My own experience and that of everybody else I've ever talked to is that clonidine's not up to very much, but venlafaxine probably is quite helpful. But all of these drugs are less effective than HRT and are associated with significant side effects. An interesting drug, which appears to be extremely effective, is oxybutynin. And so this trial compares venlafaxine as the most commonly prescribed, quote, effective non-hormonal treatment with oxybutynin. And the question is just to determine whether oxybutynin is more effective and better value for money than the vaccine. And this trial involves two groups of women. Those who have contraindications to HRT, which is group A, and those who want treatment but don't want to take hormonal medication, and that's group B. And we're here obviously to talk primarily about group A. So in case you're not familiar, both of these drugs, to use a fashionable term, are repurposed. Venlafaxine is mostly prescribed for anxiety and depression. It helps hot flushes by blocking nerve signals which result in a flush. Oxybutynin is commonly prescribed for an overactive bladder, and it helps hot flushes probably by stopping blood vessels on the surface of the skin relaxing inappropriately, which is the underlying mechanism of hot flushes. So this is the structure of the BLUSH trial, and it's a bit busy, so I'll take you through it in a bit more, little bit by little bit. So BLUSH starts off with women with vasomotor symptoms associated with endocrine therapy or menopause. And we are looking for women with at least 5 moderate to severe hot flushes daily. And these are women who've opted for pharmacological treatment that does not include HRT, and I've described the two groups. Group A are will be patients with a breast cancer family history, with a personal history of breast cancer, and with a history of DCIS. And all of these women are advised not to take HRT. But it also includes other groups. So some other cancers, it's quite common that women who've been diagnosed with endometrial cancer are advised against HRT. And then there are other conditions, a history of venous thromboembolism. HRT is generally contraindicated. Women with liver disease and some fairly obscure inherited conditions such as the Rotor and Dubin-Johnson syndrome are advised against HRT. And all of these women, if they wish to join the trial, would be in Group A. So this is the run-in. Women who've been approached and appear to be eligible and give consent are asked to complete a hot flush diary, and then the trial collects baseline data, and this process takes about 2 weeks. And we'll come on to the hot flush diary shortly. And then this is the actual structure of the trial. There are both Group A and Group B consist of 480 women. And they're randomized 1-to-1. This is an open label trial, so everybody knows what they're taking. And then the vaccine, there are 2 dose levels, so there's a dose escalation after 1 week. For oxybutynin, there are 3 dose levels, so there are 2 dose escalation steps. And the primary outcome is the comparison of the hot flush score at week 12. And the trial is powered to detect a difference of 2 moderate intensity hot flushes daily. And it allows for about a 20% dropout. And the total duration of treatment is 12 months. And there's quite a lot of data collection from patients. So there's the hot flush diary, and then there are a series of questionnaires, which I will come on to. these are the main inclusion-exclusion criteria. We've already talked about the inclusion criteria. Women over the age of 65 are excluded, and that's because there has been some concern expressed that anticholinergics, i.e. oxybutynin, may accelerate cognitive decline in older women. This is unproven, but it is a suspicion, and because of that, we've put that as a contraindication. We also don't allow patients with advanced stage cancer, and the reason for that is because there's quite a significant chance that they may change treatment in the course of 12 months, which would potentially influence hot flushes. And you can't join the trial if you're taking other pharmacological treatments unless you're willing to stop and have a washout period. And the outcome measures, we've already talked about the primary outcome, which is to compare the clinical effectiveness of extended release oxybutynin and then the vaccine. And then there are a very large number of secondary analyses related to hot flushes and night sweats, quality of life, treatment acceptability, and an economic analysis. So this is what the hot flush diary looks like. It says how many mild hot flushes have you had a day, how many moderate, and how many severe. And there's a definition. So mild hot flushes are a sensation of heat without sweating. Severe, on the other hand, a sensation of heat with sweating stopping you doing things, or night sweats that cause you from waking up. And so you record the number of each of these a day, and then the hot flush score multiplies the number of moderate hot flushes by 2 and the number of severe hot flushes by 3 and adds them all together. And so the minimum hot flush score for eligibility is 10. So whilst people say they are experiencing intolerable hot flushes at the point of joining the trial, we won't know until they complete the diary. And this has to be done daily for a week. You can do a paper version, but we've got a rather nifty phone app called MyCap. And so you can do everything by phone. So trial visits are baseline, then 3, 6, and 9 months post-randomization, and at each of those visits, patients are provided with a 3-month supply of study treatment. Participant and clinician-completed questionnaires, there are rather a lot of these. So participants are reminded to complete their questionnaires via MyCap, so it's brilliant, you get a notification. Fill out your hot flush score diary, please. The baseline week 12, month 6, month 12 questionnaires take the best part of 30 minutes to complete, whilst the week 4 and 8 questionnaires are much shorter, 5 to 10 minutes. And the clinician-facing forms are completed at baseline 3, 6, 9, and 12. And 12 months. And all data entry is via an ECRF system called REDCap, and MyCap actually links into REDCap. So the data entry is actually quite straightforward. So these are the trial timelines. All approvals are in place with the exception of MHRA. So there's a big backlog in MHRA currently approving drug trials. So the application was made in March, and here we are in November. We still don't know when MHRA say they're going to approve it. But we hope that we will get the first sites open in January next year. There's an internal pilot review to show that we are able to recruit patients in November of next year. The recruitment ends in summer 2026, so there's a 30-month recruitment period, and then there's a 12-month follow-up to get all of the data from the patients who joined right at the end. The trial is run from the Nottingham Clinical Trials Unit, and the chief investigator is Melanie Davis at UCLH, and Zach Nash, who's a research fellow and co-applicant. And locally, I think Anne Armstrong is the local PI, and hopefully we will be able to answer an interesting question with your assistance. Thank you.
Thank you. That's great. We'll do questions at the end of the end of the session. Great. So, kind of following on from that trial, which I think we'll all be very keen to become part of around the region because it fits in with everything we're doing for the endocrine therapy side effects. Next is Sophie Green, and she's a research fellow from the Leeds Institute of Health Sciences, and she's going to talk to us about the Rosetta trial.
Hi everyone, thank you very much for having us here today. So I'm Sophie, I'm a research fellow at the University of Leeds, and just to say that I am presenting on behalf of Professor Sam Smith, who is the principal investigator for the Rosetta programme. So a little bit about Rosetta to start off with. So it stands for Refining and Optimising a Behavioural Intervention to Support Endocrine Therapy Adherence. And endocrine therapy adherence in our context is all about women with early stage breast cancer who have been prescribed adjuvant endocrine therapy for 5 to 10 years to prevent recurrence and mortality. So as we've kind of heard this morning, obviously endocrine therapy has a lot of benefits, but there are a large proportion of women who don't adhere to this medication. So this trial is all about thinking about behavioural interventions that we can use to support adherence in this population via a multi-component intervention. So we have had quite an extensive development process for developing our intervention. I'm going to give you kind of a snapshot of it today because I don't have time to talk about every individual aspect. So I'm going to jump in at stage 3, but just before I do that, in the first couple of stages of intervention development, we undertook quite a few reviews to understand really what are the barriers of women taking this medication and what's sort of preventing them from adhering to the medication. And as you might expect, there's loads of different barriers to women taking this medication across the span, but there are some that are more sort of consistently reported and some that we might be able to support via a behavioural intervention. So we worked with a lot of patients and stakeholders to think about specific targets for the intervention, and that led us to design a multi-component intervention with 4 separate parts, which we call intervention components. So it's probably easiest to start by reading this from right to left. So our outcome of the trial here is to improve medication adherence. That's ultimately what we want to do. And in the middle 2 columns are the sort of targets for the intervention. So these are some of the barriers that women report to adhering to the medication. So we've got forgetfulness. So a lot of women are reporting a lot of brain fog during this period. And the idea here is that if we can support women to form habits around the medication taking, hopefully that will reduce the forgetfulness of taking the medication. Below that is medication beliefs. So this is in the form of low beliefs about the necessity of AET and quite high concerns about it. So often some misconceptions surrounding the medication or understandably concerns around the sort of side effects that we've heard about today. So this is a really consistently reported barrier to taking the medication, and so we're trying to support a more sort of positive belief about the medication and to reduce any misconceptions to ultimately support adherence. The third row here is all about psychological distress. So obviously in this period, a lot of women do report psychological distress, and particularly when their more sort of active hospital-based treatment has ended, there's a lot of reports of kind of feeling a little bit isolated, and it's a very different feeling of when they had a lot of appointments and then they're kind of left to take this medication. So here we're trying to increase something called psychological flexibility, and that's a process of kind of approaching experiences with openness and awareness, and it's all about engaging with activities and behaviours that align with your values. So hopefully taking the medication would align with their values, but it also acknowledges that for some women taking this medication might be a choice that they want to undertake, and it helps them to make that sort of informed choice for them. And then finally, the final component is all about side effects. So we've heard quite a lot about side effects this morning, so I won't go into loads of detail about it. But obviously that is a massive barrier to women taking this medication and why they might stop. So over on the left-hand side, you can see that we've developed 4 intervention components, each targeting one of these barriers. And I'm going to talk to you a little bit more about the intervention components now. So we've got a series of text messages, an information leaflet, an acceptance and commitment therapy program, and a side effects self-management website. So to start off with the text messages, these underwent quite a rigorous development process with kind of workshops from behaviour change experts and also surveys and focus groups with women with breast cancer taking this medication. So this is just a few of the messages that are sent, and underneath them is the kind of theory that they're based on as well. So they're all sort of tips and tricks of helping people to form habits surrounding their medication taking. And these are sent across a period of 4 months, so they start off a lot more frequently, so they're daily for 2 weeks, and then they reduce in frequency over the period of 4 months. Hopefully, as people form habits, they're sort of less reliant on a text message to prompt them. Our second component is an information leaflet. Again, it's undergone quite a lot of input from women with breast cancer to sort of decide on what to include in the leaflet. So it has sort of 5 components within it. So its diagrams are really explaining how the medication actually works and how it achieves its benefits. It's got a lot of icon arrays and infographics about the benefits of the medication to really emphasise that. And it also talks about the prevalence of side effects, because we don't want to shy away from that. A lot of women do want that information kind of upfront. So it tells them what they might expect from the medication. It answers some common concerns that women have about the medication, and they particularly sort of surround side effects as well. And then it also has some quotes and pictures from our patient involvement panel about their sort of motivations to take the medication. And that specific part of it has been really well received by participants. So onto our acceptance and commitment therapy program. So for anyone that's not familiar, acceptance and commitment therapy is a kind of newer form of cognitive and behavioural therapy, and it includes things like mindfulness, and as I mentioned earlier, sort of engaging with your values, all to enhance something called psychological flexibility. So this programme was adapted from an existing ACT intervention that was very positively received in a different population, and we also added some additional exercises to foster self-compassion in these women, as that's something that's been really positively evaluated in a different trial in the same population. So what this programme is it's 4 participant modules, and they're in the form of 4 booklets, each focusing on a different ACT-based skill. And these are supported by 5 sessions with a therapist that are 25 minutes long. And it has sort of home practice tasks in between the sessions to complete as well. Finally, onto our side effects self-management website. So what this includes is an overview of some of the most common side effects that women report from these medications, and different ways that women can self-manage these strategies. So things like hot flushes, night sweats, fatigue, and it goes through the different self-management strategies that might be available. And it also gives an evidence rating for these. So based on some work that we've done, some of these strategies don't have a huge amount of evidence surrounding them, but they might work for some women. So it sort of is upfront about that and what the evidence is around them using a rating scale. So during our intervention development process, we were quite keen to consider the actual implementation of this intervention, if it is effective, because we don't want to kind of use loads of resources and then it not be able to actually be delivered anywhere. So we had a lot of consideration around the sort of cost, the time, and particularly kind of therapist time in delivering the therapy component. And the type of trial design that we're using will enable us to identify the most effective combination of those 4 intervention components that I've talked through to support medication adherence without exceeding a pre-specified cost. And the cost I have on the board is based on health economic analysis, and that was what was considered kind of cost effective to be delivered within the NHS. So onto our evaluation, we are using a sort of slightly different type of evaluation in that we're trying to optimise this intervention. So typically you might expect in a randomised control trial participants be randomised to kind of receive the whole intervention or just receive a comparison or usual care. Whereas here we're using something called a factorial trial design. So participants are randomised to receive any combination of those 4 intervention components that I've spoken about. So to kind of demonstrate this, there are 16 conditions within the trial. So women randomised to condition 1 would receive all 4 of those components, whereas someone randomised to condition 13 would receive just the ACT and the website components, and so on. So the reason that we're using this trial design is because we can gain a lot more information from it. So we can understand which of those individual components might support adherence. We can understand how those components might interact with each other. So potentially some of the support might work better when it's delivered together, but potentially some of it might work worse when it's delivered together. And ultimately what our aim to do here is to think about what is the most effective combination of those intervention components and what can we remove from the intervention. So if there are parts of it that aren't really contributing, aren't having a positive effect, or are potentially even having a negative effect on adherence, we don't want to be sort of wasting resources on delivering those things. So that's what we're trying to do here, is to try and improve the efficiency of the support that we're delivering. So where are we at with this trial? So we have conducted an external pilot trial where we randomised 52 women across 5 NHS sites across the UK. We have completed the analysis of this now, and I'm pleased that we are progressing to a kind of full optimisation trial, so a much larger one, to understand how this intervention is working in a bit more detail. So the primary aim of our full optimisation trial is to determine the most effective intervention package for supporting AET adherence, so the most effective combination of those 4 components that I've spoken through today. So our trial is due to open in January 2024, and we're going to have a 15-month recruitment period. We are aiming for 25 NHS sites across the UK to be involved in recruiting participants, and these are secondary care NHS trust hospitals providing services for breast cancer patients. And we are looking to recruit 512 participants to the trial. And so this is probably a good time to mention that we are actively looking for sites to take part in this trial and to support us in our recruitment. So if there is anyone that might be interested or available to support us, then I would definitely be interested to hear about that. And so please do get in touch with us or have a chat with me. So just in terms of our key eligibility criteria for the trial, so it is just women with stage 1 to 3A breast cancer who are currently prescribed AET, and they have to have finished their active hospital-based treatment within the last 12 months. A few of the key kind of exclusion criteria is they can't have stopped taking AET due to clinical contraindication, they can't be involved in a similar research trial, and they can't be currently attending psychotherapy or psycho-oncology because it might interact with that ACT component that I've spoken through. Finally, just to acknowledge that this is work from a much, much larger team than just myself, and just to re-emphasise that if you would like to support this trial or you are interested or have further questions, please do get in touch. We would really love to hear from you. Thank you.
Fantastic. I think you're going to be inundated at the break with people coming up and asking how we can get involved with that around here. The final speaker of this first session is Alex Lewis. She's one of the consultant medical oncologists at the Christie, and she's going to talk about endocrine therapy and is 10 years too long? So let us know, is 10 years too long, Alex?
Hello. So this is a fairly data-heavy talk, but I'm hoping I've managed to get it in a fairly clear way through. Just pop some disclosures on. So I'm just going to talk a little bit, first of all, about what I think we are generally doing currently, and then a bit about the evidence base for what we're doing and different lengths of extended therapy and some things we need to consider and how we might want to change our practice based on all of that data. So current recommendations for endocrine therapy. there is a huge wealth of data, obviously, for tamoxifen, which is what we recommend for premenopausal women. This is obviously very old data now, but very nicely summarised from a number of trials by EBC TCG, showing a very significant recurrence in both reduction and mortality, both for node-negative and node-positive women with 5 years of tamoxifen. For postmenopausal women, we predominantly recommend an aromatase inhibitor. I know this is a wordy slide, but essentially there's around a 3% decrease in recurrence with either 5 years of AI or 2 to 3 years of tamoxifen and then 3 years of AI, compared to 5 years of tamoxifen for postmenopausal women, and a coming up on 1% decrease in mortality. And so generally that is why an AI for postmenopausal women is recommended at least at some point during their treatment. No one's sort of directly compared the 5 years of AI to 2 to 3 years of tamoxifen and then AI, so we don't know exactly which one is better. And it's just sort of important to note within that that really was for everyone. There was no particular heterogeneity in those cohorts between sort of nodal status, age, anything like that. So current recommendations are, I think, roughly working on this schedule, but for stage 1, 2A, less than T2 tumours will recommend 5 years of endocrine therapy. For T2 node negative, we'll be thinking about offering 10 years of endocrine therapy, and for node positive tumours, we are generally recommending 10 years of endocrine therapy. So, evidence-based, 5 years of tamoxifen was better than 1 to 2 years, quite convincingly. The mortality reduction is nearly double for 5 years compared to 1 year. That risk ratio is present, so with 5 years of treatment in years 0 to 4 and also in years 5 to 9, but the risk ratio for years 10 to 14 was 0.97, suggesting that there really wasn't any further gain or benefit after that point. But we do know that with 5 years of endocrine therapy, there is still a very significant risk of recurrence and mortality. So there remains an annual 1% mortality rate for N0 patients, even at 20 years, and it's a 2.3% risk for N2 plus patients. So that's sort of one of the things that has led people to look at extending that therapy over the years. So for extended therapy, Atlas looked at 10 years of tamoxifen versus 5 years of tamoxifen and showed a 3.7% absolute benefit in recurrence risk and a 2.8% mortality risk. Although it is tamoxifen, 90% of women in this trial were postmenopausal, not premenopausal. And just to sort of briefly mention, the rate of endometrial cancer was doubled, and there was a slight increase in death rate. So then, there's been a number of trials in recent years that have looked at 5 years versus 7 to 8 years. So GYM4 data and NSA-BP B42, they all had a stem of usually tamoxifen, although NSA-BP B42 did allow an AI up front, and then extended treatment taking them to 5 years or somewhere between 7 and 8, 8, 9, and 10. Of usually an aromatase inhibitor. And so the columns in bold at the side for disease-free recurrence, they all showed a 3 or 5% benefit in reducing recurrence risk, and GYM4 did show a survival benefit that was significant at P0.03. The others weren't significant, but there was a small mortality benefit there. However, then 2 other trials came along, so IDEAL and ABCSG16, and all big trials with postmenopausal women, similar sort of baseline stem with some tamoxifen or an AI early on, and then they randomised women to complete 10 years in total, or around 7.5 years in total. And really, you can see that these absolute differences for disease-free recurrence are much, much smaller, and they were non-significant in both of those studies, and certainly no overall survival benefit within that. I think that's very nicely shown by these Kaplan-Meier curves. So this is from ABCSG16. Really no separation of those curves at all, with either 2 extended years of treatment or 5 extended years of treatment. But quite clearly an increasing risk of bone fracture from the osteoporosis effect of the aromatase inhibitors. So some of the things to consider within this data. Some of these trials included low-risk patient populations who we wouldn't normally offer extended endocrine therapy to. None of these trials, with the exception of 10% of women in Atlas, have included premenopausal women, so that really is a data desert there. We don't know what is best to do for those women. And it doesn't account for the impact of ovarian function suppression, which we know is important and adds an additional benefit on top of tamoxifen for high-risk premenopausal women. Discontinuation rates were high, which I think really does fit in with some of what we've talked about already this morning. So for an example, in GYM4, nearly 40% of women did not complete their extended therapy. I think it's really interesting then that these trials did show a significant benefit despite that. There clearly is some benefit to extended therapy, but we obviously need to remember that these drugs are not actually that easy to take and tolerate for a long period of time. It's important to note that a significant proportion of the disease-free survival benefit actually comes from a reduced contralateral breast cancer risk rather than reducing the risk of recurrence in the breast itself or reducing the risk of distant metastatic disease. It does do that, but the majority of it comes from that contralateral breast cancer reduction. Endocrine therapy toxicities we've already talked about a lot this morning. They are very well documented that they have an impact on quality of life, but there are other side effects that we need to consider. Endometrial cancer rates are 4 times higher with 5 years of tamoxifen than with a placebo. The risk of cardiovascular events goes up with aromatase inhibitors, and it isn't just things like dyslipidemia and hypertension. That's why it happens, that's the cause of it. But there's a 15 to 20% increased risk of cardiac events, and that includes things like heart attacks, strokes, significant anginas. Tamoxifen, conversely, has a slight protective effect. But I think the big one probably is osteoporosis as well. So we know that aromatase inhibitors speed up bone loss. In MA17, which I haven't included the data from in the interests of time, 15 years of endocrine therapy definitely didn't show any benefit in survival, but the fracture rate was, 1.5 times. And in a meta-analysis, it looks like extended endocrine therapy increases osteoporosis rates by about 50%. I ran out of time to get some decent numbers on this, but osteoporosis is, very, very closely, if not inextricably, linked with frailty, which, as I think we all know, is having a very significant impact on our ageing population and our health system overall. It comes with an increased risk of fractures and significant morbidity and mortality for these ladies. So whilst we are obviously all very keen to cure our patients of breast cancer, we have got to consider the other impact on their overall health in doing that. So suggested practice, and apologies, this is wordy again, but Sangallen Consensus of 2023 looked at this and in a change from previous years where they'd heavily favoured 10 years of therapy for, quite early stage disease. For stage 1 disease, the majority at Sangallen were now supporting 5 years of ET. For stage 2 node negative, it was a bit more of a split between 5 and 7 to 8 years. For stage 2 node positive, again, a fair majority were recommending 7 to 8 years of treatment. And at stage 3 disease, so those real node positive, heavily node positive ladies, a fair majority were favouring 10 years. Almost all panelists, and I'm sure we would all agree, recommended that the duration should be based on an individual patient's risk factors, tolerability and preferences, and that is, I think, very important within this. But I do think, given the data that we've got showing that really going to 10 years beyond, say, 7.58, doesn't add a huge amount in terms of survival benefit, I think this would be a reasonable practice for our postmenopausal women. We haven't got a huge amount of data for our premenopausal women, and that would need to be a further discussion. But I think 5 years of ET for stage 1 tumours, for stage 2 that are node negative without any obvious adverse risk features, I think that would be reasonable. I think stage 2, but where there's things like LVI, grade 3 disease or significant multifocal disease, 7 years. Certainly stage 2 node positive disease, 7 years. And again, I think for certainly heavily N2, N3 positive ladies, we probably do still want to think about 10 years there. But obviously that is a suggestion, that's something we need to come to an agreement as an area on. But with that, thank you.
Yes, thank you very much, Alex. I think that will be a topic of conversation around our MDTs around the region to get some regional consensus about changing the kind of timeframes on ET for these different ladies. So we have probably about 10 minutes or so for any questions from all of our speakers. There are some roving mics that can go around the kind of room. So just if you just raise your hand and we'll try and pick people for any questions. So has anybody got anything that they've been wanting to ask from any of the speakers this morning? Oh, go on, Nick.
Just out of interest, it's for Claire, the risk-reducing medication, how long would you recommend ladies take that? And is it an alternative to surgery?
Is this mic on? Can you hear me? Yeah. So the recommendation is for 5 years. We're not recommending any longer than 5 years. And certainly the studies show, now bear with me, I'm not a geneticist, I'm a surgeon, but I've been prepped. So the studies show that the benefits, certainly of anastrozole, continue for potentially, for tamoxifen, continue for potentially 15 years afterwards. I mean, it's phenomenal in terms of the continuation of the benefit. There's less evidence in terms of anastrozole. We're talking about 7 years. It's just what the trial data shows. And then for aloxifene, we're going for a few years or several years because we've not got the data. So it's that 5-year course, but it's all about your overall lifetime reduction in exposure to estrogen. So the benefits go on for a lot longer. So it's 5 years hard stop. In terms of an alternative to surgery, that's all about patient preference, isn't it? So if a patient was in that very high risk group, they will still be referred over to St Mary's for that discussion of risk-reducing mastectomy. And that won't stop. They will still be going through that specialist tertiary clinic in St Mary's and being referred over to MFT for risk-reducing mastectomy if they're eligible and that's what the patient wants. This is for that group that are high and moderate risk that are not currently normally discussing risk-reducing mastectomy, so their only option is screening, and they can't really actively do anything to reduce their risk. So I think this is a very good option to be discussing with patients.
Okay, anybody else? Any other hands up around the room? Vivek?
Thank you. Thank you very much. That was very good. I think I'm really encouraged by the endocrine therapy management thing, because that really is one of the big issues that we see when we discharge patients from oncology. So that's excellent. One of the questions I just had for both the research teams here about management of hot flushes, etc. Did I hear correctly that the eligibility criteria is for women with breast cancers? Is there a reason to exclude men from these studies? Because one of the big unmet needs in male breast cancer is the lack of research, number one, and almost all the information that's there out there on the net is focused on women as well. So I'm just wondering, is there a reason to exclude them?
As far as blush is concerned, there's not a good reason apart from the trial is being run by a gynecologist. They don't think about men, I'm afraid.
I also don't have a good reason for you of why we've excluded men.
Might be worth considering a protocol amendment.
I'm not sure the team will be delighted with my suggestion, but yeah, no, I think it's a really good point, and it's a very relevant point that it's a hugely under-researched area that we should probably consider more, definitely.
We'll add that to Claire's to-do list.
I've just added it, Vivek. Thank you so much for bringing that up. It's so often forgotten. It's not okay. So, as we're thinking about those resources, about, patient visibility and getting real diversity within those videos that we're making, thank you for that point. And we'll find a man who will talk about their experience, and we'll add that to the list. Thank you so much.
And the blush trial management group needs to consider the male sex.
Okay, any other hands? So mine was just another quick question for the trial groups. You said that Anne's the PI locally for Blush. In terms of practical terms, if any people in this room want to get their units involved, what should they do? Should they contact you, Anne?
Yeah, I think you're looking at opening it at MFT. Yes, contact us when it's open. And I think you're looking at opening it at MFT as well.
Yep, so excellent. So we will be on board as well. But other regions, as they go through you or the trial team directly?
Go through.
Go through the trial team directly.
I mean, the process of recruiting patients into Blush is actually quite complex because there's so many different routes into the trial. So Group B, which are the patients who don't want to take HRT but could, be largely recruited through general practice and also menopause clinics. Group A patients are likely to be recruited through menopause clinics, potentially family history clinics, as well as breast oncology clinics. The route of referral will be very much locally defined. But on top of that, there's there'll be remote management of patients in Group B from Liverpool. And so those patients will probably never attend clinical in person, but will be entirely managed through remote consultations.
Okay,
so,
go on.
So I think it will evolve. It's my feeling.
And if people who are interested for your trial, if they email the email address you had on your slides, is that the best way to get?
Yes, please do pop us an email if you're interested, or I'm here in the first break if you've got questions as well. Thank you.
Fantastic. So we're just about on time for break. Any last minute questions before we let everybody go for a well-deserved cup of coffee? No? Great. So back after coffee at 11:40, please, for the next session. Thank you, everybody.